Today we'll be covering Chapter 34, Chest Trauma. This is brought to you by Southern Star Health Education, and we'll be using the Prehospital Emergency Care 11th edition. Our topics for today, we'll be covering the chest, a little bit of anatomy and physiology, general categories of chest injuries, specific chest injuries, assessment-based approach for chest trauma, and we'll be also summarizing the assessment and care for chest trauma. Chest injuries may not have a dramatic appearance and can be overlooked. Chest injuries can be lethal. You have to maintain a high index of suspicion based on the mechanism of injury that you've observed. A little bit of anatomy of the chest. The chest is also known as the thoracic cavity. It is bordered inferiorly by the diaphragm. It contains vital organs like the lungs and the heart. The vital organs in the chest are protected by the ribs themselves. And the thoracic cavity is lined by two layers of pleura, the visceral, which covers the organs, and the parietal, which covers the cavity itself. Here you have a diagram of the chest cavity. As you can see that the ribs protect the heart and the lungs and the major blood vessels. You also have inferiorly the diaphragm right above the stomach. Normally there's a negative pressure that acts like a vacuum. This holds the visceral pleura together with the parietal pleura. Just remember that the visceral pleura would be surrounding the lungs themselves, the organ itself, and the parietal pleura covers the cavity itself. Now, this usually keeps the lung expanded to the chest wall. There's a couple of situations where you can actually get the loss of this negative pressure. Normally, one of them would be a penetrating trauma, like a knife wound to the outside of the chest. The other one would be a pulmonary blood rupture, which causes the lung itself, the lining of the lung, to actually seep out air into that negative pressure. General categories of chest injuries. You have open chest injury, which is caused by a penetrating injury. Cavitation occurs with gunshot wounds. If one of the great vessels in the chest wall is injured, it can result in immediate death. A pellet fired from an air gun creates an extremely small entrance wound. Although the pellet wound may be very small, a pellet can actually penetrate the thoracic cavity, ricochet around, and potentially cause lethal injuries by rupturing blood vessels whatsoever. When you suspect trauma, you must expose it closely and closely inspect the chest to avoid missing potentially lethal injuries. Chest injury may actually involve injury to the heart, major blood vessels also. May actually include a pneumothorax. Penetrating trauma can actually interfere with the negative pressure needed for inhalation by allowing air to actually enter through the wound itself, causing the lungs to collapse. Closed chest injuries, they usually result from blunt trauma. You can actually injure the heart, lung, great vessels, and other structures that are within the thoracic cavity. And when it comes to flail chest, this usually results when there's two parts of the same rib broken, causing a paradoxical movement. Segment. This results when two or more adjacent ribs are each fractured in two or more places, creating a segment of the rib or the rib cage that is not attached to the rest of the rib cage itself. The flail segment interferes with chest expansion and changes the enthothoracic pressure. This slide gives you an example of what it would look like. A flail segment, and then you notice that the ribs are broken into two different pieces within the same rib itself. It can actually be several ribs also, and this can actually cause damage to the lung by puncturing it, and it can also cause a failure in the respiratory drive. The effects of pressure during inhalation and exhalation explain why paradoxical movement happens. Paradoxical movements, if you notice on this slide, they will, whenever you do inhalation, you have the opposite effect where in the flail segment. So the chest is expanding, though the broken ribs will actually go inward, and while you're exhaling, those will go the opposite way as the rest of the ribs. Flail segment is drawn inward as the rest of the lungs expands with inhalation. The flail segment pushes outward as the rest of the lung contracts and with exhalation. To avoid further compromise of chest movement, do not place a patient on the injured side. Do not stabilize the chest wall with objects that restrict chest wall movement or motion. Consider CPAP if a patient demonstrates signs of respiratory distress. Pulmonary contusion. Bleeding occurs in the lung tissues and around the alveoli and in the interstitial spaces. Gas exchange is severely impaired, leading to severe hypoxia. A patient who has suffered a direct blow or any other blunt trauma to the chest may actually have pulmonary contusion. Here we show that there's bleeding into and around the alveoli and the space between the alveoli and capillaries. This greatly reduces the exchange of oxygen and carbon dioxide in the affected area. Pneumothorax is an accumulation of air in the pleural space, resulting in the collapse of a portion of the lung. Causes may be a paper bag. Usually this effects may occur upon sudden compression of the chest itself, penetrating trauma, or spontaneous pneumothorax. Open pneumothorax. This is caused by an open chest wound that allows air to enter the pleural space with inspiration. The open wound must immediately be occluded, first by your gloved hand and then by an occlusive dressing. Here's a diagram of an open pneumothorax. If you notice that one of the lungs is actually collapsed, and this is caused by air actually entering the chest cavity, actually causing that negative pressure that holds the lung to the wall to decrease. So then you have a collapsed lung. Tension pneumothorax is immediately life-threatening. Air accumulates in the pleural space with no route to escape. This increases the pressure in the thoracic cavity. The lungs, heart, and large veins are compressed, leading to poor cardiac output and hypotension, poor ventilation and oxygenation, and severe hypoxia. Now with time, air continuously fills the pleural space, lung collapses, pressure rises, and the trapped air compresses the heart and the other lung. Thorax is when you have blood in that pleural space. This usually compresses the lung itself, may occur in open and closed injuries, and the blood loss can actually result in shock. Signs and symptoms: severe respiratory distress, signs of shock, and absent breath sounds on the affected side. On this diagram, we show where you have blood actually accumulating in that pleural space. Now, this also is, you lose that negative pressure that actually contains the lung to the wall itself. And this causes actually that blood loss that you have there might actually start giving you signs and symptoms of shock. Traumatic asphyxia is a sudden severe compression of the thorax, which causes rapid increase in ventrothoracic pressure. There is a backflow of blood out of the right ventricle into the upper body. Severe chest compression puts pressure on the heart and forces blood back into the veins of the neck. This may actually cause severe lung damage. Cardiac contusions is associated with blunt trauma from violent compressions of the chest. A bruise to the heart wall may actually form, or a heart may actually be ruptured. Disruption of electrical conduction may actually occur. Primordial cordis is a sudden cardiac arrest from blunt force to the precordial area. A blow to the chest during a vulnerable period of the cardiac cycle can actually lead to a lethal arrhythmia. You have to start CPR and apply the AED immediately. Cardiotamponade. It's bleeding into the fibrous sac around the heart from blunt trauma penetrating trauma. Compressions of the ventricles results in inadequate ventricular filling and reduced cardiac output. Signs and symptoms of pericardial tamponade: you have jugular vein distension, signs of shock, tachycardia, and decreased blood pressure, narrow pulse pressure and weak pulses, or radial pulse diminished on inhalation. Injury. The fractured rib may actually cause damage to the lung or the intercostal vessels. Rib fractures is less common in children. Signs and symptoms of rib fracture include pain with movement and breathing, crepitation, tenderness upon palpation, chest wall deformity, inability to breathe deeply, or coughing or tachypnea. You have an example here of the way rib fractures usually can actually occur. Now remember, within the rib itself, on the bottom portion, you have a vascular package, which includes a blood vessel. The blood vessel is like a small artery and a small vein. Now, these can actually get damaged if the rib fractures itself. Which is characterized by air trapped in the pleural space under pressure, resulting in compression of the structures of the affected site. The mediastinum, the opposite side of and the opposite side of the chest. Is this a hemothorax, tension pneumothorax, pericardial tamponade, or sucking chest wound? The answer is tension pneumothorax. Assessment-based approach for chest trauma. Scene size up. If violence was involved, be especially careful with the scene size up. Do not enter the scene that is not safe for you to enter. Use standard precautions. Look for the mechanisms of injury, specifically in sports accidents, falls, fights, gunshots, vehicle collision, crushing injuries, or explosions. Use spinal stabilization. If indicated, form a general impression, expose and examine the chest, assess the mental status, assess the airway, and look for signs of respiratory distress. If breathing is adequate, apply oxygen as needed. Just remember that you have to maintain the SpO2 at greater than 94%. Consider CPAP for flail segments or pulmonary contusion, and do not use CPAP if pneumothorax is suspected. If breathing is inadequate, provide positive pressure ventilation. If a tension pneumothorax results in increasing difficulty in ventilation of the patient, and cyanosis is an indicator of poor oxygenation and ventilation. Pallor can indicate early hypoxia, poor pumping function of the heart, or blood loss. A weak rapid pulse can indicate bleeding or compressions of the heart. Chest injury patients are a high priority for transport itself. Perform rapid secondary assessment. Assess the neck for subcutaneous emphysema, jugular vein distension, and tracheal deviation. If indicated, apply a cervical collar after examining the neck. Chest, if not already done. Examine lateral and posterior chest. Immediately seal open chest wounds. For signs of flail segments with inadequate breathing, use positive pressure ventilation. Look for chest symmetry, paradoxical movement, swelling, deformities, crepitation, and guarding of the injured ribs. Auscultate for lung sounds, assess baseline vital signs, and obtain a history. Look for cyanosis, dyspnea, tachypnea, and bradypnea. Obvious signs of injury, hemoptysis, signs of shock, and tracheal deviation also. Look for paradoxical movement. Look for open wounds, subcutaneous emphysema, jugular vein distensions, and absence or decreased breath sounds. Pain on the site of injury, especially with inhalation. Failure of the chest to rapidly expand or expand normally. Weak or absent peripheral pulses, or drop of systolic blood pressure of greater than 10 milligrams of mercury on inhalation. Maintain an open airway, use inline spinal immobilization if indicated, maintain adequate oxygenation, and reevaluate breath sounds, avoiding forceful ventilations. Positive pressure ventilation with supplemental oxygen if breathing is inadequate. General emergency medical care for chest trauma, stabilize an impaled object in place, provide spine motion restriction or spinal injury is actually suspected, and treat for shock. Immediately seal the wound with a gloved hand, apply an occlusive dressing, and continuously assess the respiratory status. Be alert for signs of developing tension pneumothorax. Do not splint the chest wall in any way that actually interferes with chest movement. Maintain oxygenation, consider CPAP, positive pressure ventilation if breathing is inadequate. Apply a sling and swath to stabilize an area of of a rib injury. Be alert for signs of deterioration such as increasing difficulty in breathing, decreasing mental status, decreasing breath sounds, or worsening cyanosis and shock. Reassessed for missed injuries, interventions, and vital signs. EMTs Roxanne Friedman and Laura Cahill are on the scene of a patient who was ejected from the driver's seat of a vehicle that rolled over multiple times after leaving the roadway at a high speed. As Roxanne maintains an inline stabilization of the spine while opening the airway with a jaw thrust maneuver, Laura quickly exposes the chest and listens to breath sounds. No breath sounds on the right. There is jugular vein distension, says Laura. Now, what injury suggests by the mechanism of injury that an EMT finds so far right now? Also, what immediate interventions are required? In the primary assessment, the EMTs find the patient responsive to pain with rapid, shallow respirations of a weak, rapid pulse that disappears on inspiration. Roxanne begins positive pressure ventilation as Laura requests ALS backup. With the assistance of other responders on the scene, the EMT perform a rapid secondary assessment and package the patient for transport. The EMTs meet the ALS unit at the agreed upon point. Roxanne reports ventilations are very difficult. After a quick assessment, the paramedics perform a needle chest decompression, which immediately improves the patient's ventilatory status and circulation. From the given scenario and the patient assessment findings, what do you suspect the patient had?